you how complex my life is. But what I would like to do, I would like to thank you all for being here. I would like to thank particularly the friends and colleagues from the Mayo Clinic, St. Catherine Hospital and ISIS for a wonderful collaboration we are having for many years, 21 years, and what I'm going to show you is other part of my life which is related. During my MD PhD period when I was working with osteogenesis imperfecta, 1992 described the mild type of osteogenesis imperfecta, and I was involved deeply in work with the cartilage. So, as you know, the life is very complex for all of us, and everything is changing. You cannot predict in which direction you will go. So, what was happening, St. Catherine Hospital, the most of you are familiar, is having a very unique approach to the healthcare. It's kind of integrated healthcare, where we are starting from the whole genome sequencing to the point of the entire diagnostics, treatment, surgeries, and finally the rehabilitation. And what is also very unique, you know, if you're treating the patient, and most of you who are physicians, you understand, you know, the patient is quite happy if you do reconstruction of anterior crucial ligament, he's happy to work. But it's very tricky to work with those patients. We are talking about world-leading athletes. They are not happy if they are not coming back to the full shape and start doing training. So you can imagine if you're in charge of the Croatian national football team, Modric and the rest of the guys. Real Madrid doesn't care much if he's not back in shape. So that's the Croatian national team, and Davis Cup, there's the director of the hospital right here, and just recently became official hospital of the World Taekwondo, which is covering about 110 million members. So that's particularly why it's important for us to be very, very sensitive about everything what I'm going to show you today. So cartilage injury and repair is kind of a priority. It's what we see in the life of the athletes. And osteoarthritis, most of you are very familiar with what I'm going to show you. But I think for most of the people, it's critical to understand that we are talking about all tissue of the joint involved. Not only cartilage. It's one of the largest mistakes most of the people are making on the point. So over 50% of the osteoarthritis is showing synovial inflammation, which is eventually bringing problems because you have to have a fusion. And I will show you in a few examples how sufficient treatment can get rid of the fusion but also causes simultaneously problem at the same time. So, as you know, the women are almost twice as likely to have osteoarthritis than men. And the estimation is that about 9.6% of the men and 18% of the women over the age 60 will suffer from osteoarthritis. It's a huge. And I'm going to be focused today mainly on the knee osteoarthritis because as we learn more, we see it completely looks like different mechanism for hip osteoarthritis. The thickness of the cartilage is different. In the knee, you're having between 2 and 3 millimeters. In the hip, you make between 1 and 2, and so on. But that's scary. If you see that estimation is that about 1/10 of the population will eventually have osteoarthritis, that's a recent data. And the expenditure in 2007 is about almost 200 million, about treating of osteoarthritis. The main problem with the cartilage, and there's so many people deeply involved with the cartilage, understand, the main problem with cartilage is avascular, aneural, and receiving all food by diffusion. So the question is, how possibly cartilage can be healed? It's a big question. And in order to understand that process, we did a bunch of study for the last 25 years. But for you who are not deeply in, you can see that cartilage having very specific structure and chondrocytes are having gradual differentiation. If you go a little bit further, knee osteoarthritis is a big problem. I don't know how many orthopedic surgeons are, but I know certainly there are. But it's critical to understand the mechanics of the knee. The ratio, what is happening between anterior crucial ligament, which you can see right here, which prevents femur from sliding back on the tibia, and that's one of the most common injuries which is happening in the case of the sports injuries. the structure is just anatomy, where you're able to see the same pericrucial ligament, which is usually breaking, and then you're having joint capsule, and here's the structure indeed involve the medial and lateral meniscal, which are critical to keep the stability and perfect squeeze of the knee. Okay, what is the main problem? Because if you don't understand molecular structure of cartilage, you cannot think, and that's why I love about your lecture, because you really went so deep, both of you. It's remarkable. But let me tell you what I have learned in the past when we pioneered the certain things related to the cord protein. So I spent 6 years just working with the cord protein and aggrecan. This particular molecule, which is having the domain binding hyaluronic acid and having completely attached with collagen type 2, which are produced by the chondrocytes. So glycosaminoglycans, which are going to be subject to my talk today, are very critical because highly polar, attract water, and very important for us to shock as a shock absorber. If you see the molecule of the aggrecan that I just showed you, the question was in the early 90s, what are diseases related to the mutation of the aggrecan? So we worked in the early 90s with the model of the anomalia. I'm not sure if you are familiar with this model. So the chicken disease, what you see in the middle, it's a normal, and both sides are anomaly. They're having homozygote mutation of the aggrecan, which is on the exon 10, unusually big exon. So on the splicing, so many things get confused. That's exactly what I spoke with Richard if he's around. And it's something what we have found. We have found the premature termination called the TAA in the middle exon. That's a TAA comparing with the normal allele, which was a GAA. But what was really happening? You see that the messenger RNA with TAA getting rapidly degraded inside the nucleus. So you really don't have any molecules coming outside of the cytoplasmic compartment, which is empty comparing with the normal cell. So that was clear during the time. But what was not clear, what is the influence of the aggrecan mutation on the collagen type 2? So what you're able to see here on the last line that is on the milk chicken is that with the collagen type 2, it's directly correlated with the mutation of the aggrecan. So we did a bunch of papers trying to understand the mechanisms, and what you see here is a normal cartilage comparing with osteoarthritis, where it's very clear that Adam's MMPs are effectively binding the certain molecules of the collagen, and there's a cleavage side where you get read and cut those molecules. The normal cartilage, for mainly a few students, it's so critical to understand what is really happening in the real life. And basically what you see here, we are having synovium, then you are having cartilage shown in blue, then you are having time mark, you are having bone, actually compact bone, and what we call here, this portion is called subchondral bone, and most of you who are orthopedic surgeons, you understand why subchondral bone, sometimes even more important than changes on the cartilage. Unfortunately, very few people went so deep in that. And the pain, what is really happening, is happening because you are having mainly subchondral bone edema. So if you move further, that's how by arthroscopy the cartilage looks like, brilliantly smooth and so on. If you're having beginning of the damage of the cartilage, so it's erosion, certain changes happening in the synovial fluid, certain changes happening here, you're having macrophage activated. So let's see how everything looks like if you do arthroscopy, you're having shaggy carpet structure. Then if you go a little bit further, you see on histology, you're having vertical fissures. Unfortunately, most of these parts are getting broken, swimming in synovial fluid and causing inflammation. So that's what we see in our patient. However, if you go on the very last stage of the osteoarthritis, what is really happening, the fissure is coming so deep, entering the subchondral bone, you are having a bunch of subchondral bone cystic formation, and so on, and you're having heavy inflammation of the So this situation, and if you watch what is really happening by arthroscopy, you see the subchondral bone underneath, which is shown a little bit here as a reddish. It's coming and completely lost all the structure of the brain. So indeed, the question is, what to do? And in certain cases, it's very clear, and I'm showing this slide, the osteoarthritis affecting the entire structure of the brain. We have indeed International Cartilage Repair Society classification, which is helping us while working with the patient so that it can be oriented. And in most of the cases, till recently, if you're having severe type of osteoarthritis, most of the orthopedic surgeons are going to tell you it's time for prosthetics. So let's see what's changing in our life. So, cartilage generation system, I'm going to show you some beginnings, and finally I'm going to show you some very exciting recent discovery, and everything what I'm going to show you, it's on the patient. It's on the patient. Okay, so basically repair on the control defect using by scaffold, which is collagen type 1. There's a bunch of studies we have done with different groups of people. Unfortunately, the major problem is you have to do opening surgery. Nobody's crazy about opening surgery. Chances for infection and so on. So you see the changes. Subchondral bone, we are moving further. Cleaning subchondral bone, cutting the edges, and putting scaffold, which is called type 1, which is having brilliant opportunity to allow chondrocyte to migrate inside, and let's see what we have inside. So if you compare all these P's values, it's just showing you that all scores, KUS, WOMAC, VAS, the important orthopedic score, is showing you improvement in the treatment, are getting better. If you are checking immunohistochemistry, you see the type collagen 1, it's present in the place where it's supposed to be, which is scaffold, but immediately after that, if you have portion of the cartilage, you see collagen type 2, which presumably came from chondrocyte. There's no other way to do it differently. Pathology, and if you see arthroscopy, basically you're not able to see defect after 42 months of the surgery. If you see MRI, you see the cartilage is filling that particular space. However, 5 years after that, about 80% of the patient require hip or knee replacement. So let's move further. We move to the less aggressive procedure, very smart design, which is means cartilage implantation autocart. So basically, that's our patient, and most of them happening, came with osteoarthritis grade 4. That's what's happening 11 months later. Basically, you're using technology where you mix with the cartilage using thrombin, PRP, filter glue, and the patient is having revelation for at least 7 weeks, and after that, you're starting the rehabilitation. But that's what I would call primitive way of taking care of the cartilage. And what Einstein said was, we cannot solve the problem, but use the same kind of thinking we use when we create the problem. So we have to think out of the box and go further. We started with microfermented adipose tissue containing MSC treatment, and I would like to show you some of our recent results. And I'm not going to go because so many of you are experts about MSCs, and I'm not going to tell you all this. We are not going to waste time on that because you're familiar. Maybe I'm going to underline. People are getting confused between MSCs and mesenchymal stromal cells. It's just different in the bulk population, which having notable secretory modulatory and homing properties. And you'll see in a few minutes why I'm showing you this. But what we show in a few other cases, including treatment of the patient with COVID, having acute respiratory distress syndrome, my group was among 3 groups in the world that did allogenic implantation of those in treating patients. You see there's a huge immunoprivilege property, passing and making down regulation of the T cell response and so on. But that's some other story which we don't have time for that. Armand Kaplan, who is not unfortunately with us, our dear friend, Carlos and my friend, he made together with Robert Hariri a beautiful scheme which didn't change much. So everything what you see here is happening in vitro, not in vivo. That's important to remember. So we have 2 approaches. One approach was very traditional, that you are going to have a patient in the hospital. So the patient coming, you're doing opening surgery, taking portion of the cartilage, growing, coming back, and eventually you are giving back to the patient after opening the surgery, the portion of the cartilage, and hoping that everything will be good. Other technology that we applied is much faster. It was big question, is going to work. So it's a technology that you're doing by point of care. You're having a patient coming in the operating theater, And we are fortunate to have with us Professor Carlo Tremolada, dear friend, who was innovator of a certain system that start allowing you and providing you wonderful microfluorescent effect tissue in the patient. So basically, the patient is laying over the theater, 2 small cuts, you're giving it epinephrine, some little kind to get rid of the pain, epinephrine to get rid of the bleeding, going with the 2 zones, taking out, doing certification, getting rid of the garbage. Immediately after that, under ultrasound, you're doing application to the knee, and it's beautiful. So let's see what you get. Okay, for me personally, it was a huge surprise. It happened 10 years ago, when I realized that in 1 gram of adipose tissue, we are carrying 500 times more throughput than 1 gram of bone marrow. For me, 10 years ago, it was a big shock. Okay, Carlo, that's when you were young and handsome. We are still. We didn't change much. Many years ago. So that's orthopedic team at St. Catherine Hospital, where we provided the procedures, which I'm sure most of you are familiar, but what is our idea? Our idea is to protect the cells and keep everything what is possible to keep, and especially as you see the structure of the blood vessel wall is having a bunch of the cells, including pericyte and schemosome cells, endothelial progenitor cells, and so on. And these pericytes are so important because they are on all microvessels and they are multipotent in vitro. So we did indeed immunophenotyping of fresh skin and stromal plasma fraction of the patient, published a bunch of articles, show very high viability, which is about 95%. And then we did a bunch of immunophenotyping of CD45 negative cells. We located these cells, we realized and we understood the ratio, endothelial mature, progenitor, pericytes, supraventricular cells, which are having pericytes, in this particular case, always about 30% in every single patient that we are doing and applying. Then we did some adventures. So we tried to play with different procedures in order to see how we can get the best possible ratio to start with the patient. Then we've been shocked. We still don't have the answer. Why? And comparative analysis situation between female and a male on the ratio between pericytes and endothelial progenitor cells, pericytes, supraventricular cells are significantly different than in men. There's no single person that described what is happening. We saw different outcomes, but certainly it's not based, as somebody thought, estrogen and so on. So it's a big question, what is going on? It is going to help us to predict the treatment. Okay, so let's move further. So during that period, we realized, what do we have? We realized that we're having a problem with the ratio between male and female, and we moved on. So we did a bunch of other studies, and let me show you how the procedure is done. So please imagine that you are having what we call microfluorescent tissue, having all the cells, and you're just applying directly to the knee. So here's the video. So it's direct application to the knee by the procedure. Those cells are coming to the place where they're supposed to come, spending a certain period of time, and let's check what is the mechanism of those cells in real life. I'm going to show you a few important studies that we did. We started with 70 patients, and in the last slide you will realize how painful it is to do certification of the patient with osteoarthritis. You will realize how many thousand patients you have to have proper randomization in order to understand molecular mechanism. It's not just this patient is having osteoarthritis grade 3 or 4. There's so many other variables that we have to understand. So basically we did application of the patient, we did follow-up at the time 0, 3 months, 6 months, 12 months after the treatment. We did all orthopedic scales, which I'm not going to go in details. Okay? We did plain X-ray, Kellner Lawrence, we did full-length bearing X-ray, we did WAS, which is important to understand what's happening with the pain. We did COOS, WOMAC, and WAS, and let's see what is happening. In the wild, we have difficulties to understand why you are having the issue if you have the same phenotype of the patient, you are applying NSCs, but you are not see the same result. It's a very simple observation. And all of you who are orthopedic surgeon knows that before that you do any treatment, you have to figure out about your alignment. Because if you have virus a little bit, we figure out greater than 5%, what you are having because of the axis, you're having pressure to your medial compartment. So it doesn't matter what you do. If you put your MSCs, you are killing them mechanically. So if it's above 5, 6, 10%, we are doing first quality osteotomy in order to do the procedure. Okay. Then we have an important question. How are you going to measure that in the patient? In animal model, I did 1,000 animals. You can do whatever you want, according to the ethical standards. But with a human, you cannot do arthroscopy, take the tissue and measure after 0, 3, see. There's no patient in the world who is going to allow you to do that. So we have to go with different procedure. We went with delayed gadolinium enhanced MRI cartridge, very, very specific technique. So what we did, actually, it's very logic. Because glycosaminoglycans are negatively charged, same as gadolinium, so you are giving in your blood gadolinium, it's traveling, patient is walking for 2 hours according to the same standards, same number of stairs and so on. After 3 hours, gadolinium is coming from your blood to the synovial fluid and heavily competing with glycosaminoglycans. So more glycosaminoglycans, which is negatively charged, less gadolinium is entering. And if you have a brilliant expert in radiology who understand the biology, you are able to target a certain point by using MRI test like you're having, and after 3, 6, 12, 24 months, come to the same point and measure level of glycosaminoglycans. Okay, you can be expert in radiology, one of the best, but you are not going to tell me what are the differences between this point and this point right here. No chance. Even if you go deeper than our original slides, you are able to determine that this particular patient is having very good cartilage, some changes, entering subcaudal bone, and last phase of osteoarthritis. That's all. But the level of the glycosaminoglycans, collagen type 2 proteoglycan, there's no chance that you're able to see it. But if you use gadolinium, it's a different story. So you are able to see there is an 899 units, 509 units, and you are able to target this point at the time 0, 3 months, 6 months, and so on. So I have big issues in discussions with so many editors on different journals in order to have proper study, which finally we did. So we did measuring in the medial lateral femoral condyle, trochlea, tibial, and patella, and let me show you what we have done. We defined an arbitrary change greater than 15% is relevant. Everyone told us, your guy's crazy. If you achieve that, it's a miracle. So let's move further. So if you see there's a time 0, 3, 6, and 12 months after the procedure. So we've been completely shocked. First of all, I realized that most of my patients was, or the pain in rest and movement are rapidly declining. Time 0, 3 months, 6 months, 12 months after treatment. But if you go on the particular, let's say lateral condyle of the femur, 4, 7, growing up to the 83%. Wow. Based on our knowledge, the first evidence showing that the level of the proteoglycan is increasing after the treatment. So we've been back and forward with the reviewers, fighting, sending the patient, all of those data, and so on. But every single patient you do, it's the same. Then we did a bunch of studies, follow-up, showing statistics. Here's the patient that allowed us to show. He was not able to do any extension or flexion. That's the patient. He was happy to show. And so many of them. Okay, so let's move a little bit further. We have many discussions. There's actually, from the Spring of Nature that we published as a model, I've been asked to show. And Arnold Kaplan did a wonderful work. And he was really pioneering fantastic things. But what we have found, it's actually everything what is complex in life, it's less complex than we thought.
So what we believe that is happening is the following. So if you are having osteoarthritis right here, and if you are putting your microfermented fat tissue, having parasites, some other things, so basically, those cells hate inflammation more than anything else. Once when they're in inflammation environment, they're changing phenotype. They're starting to be activated, having interaction with what we show with the progenitor cells, and start producing, which all of you completely familiar with, allotropic immunomodulatory antibiotics, because L-37 is one of the most potent natural antibiotics. So key situation. We move further. We did huge review, and there's actually my PhD student who is sitting right here, so we can speak for hours about incredible immunomodulatory, trophic, angiogenic, anti-apoptotic, anti-scaring, antimicrobial effect that we witness on our laboratories. But we have to go further there because there's a bunch of other data. So he is Arnold, and I have to give him credit for wonderful things when he proposed to change mesenchymal stem cells in medicinal stem cells because of the mechanism. So that's Arnold, and I greatly appreciate his fantastic work and his friendship and support because of the very, very simple mechanism, the injury-specific drug stop. Okay, let's move further. It's not all. So if we check what is happening after 12 months, because I'm very much interested to see how long that effect is. So see, so we did 20 patients, we did all study, okay, coming back. 85% of the patients who came to us to do prosthetics with osteoarthritis grade 3 or 4, 1 year after procedure with the prosthetic. Let's move further. We published those data. We moved to the 2-year study. Patient assessment, same criteria. Over half of the measurements show significant improvement 24 months after the intervention. The degenerate index grow as we expected. And I can tell you right now, the conclusion is that we understand that the regenerative effect 2 years after procedure, it's allowing us to say it's long-lasting. All evidence showing you improvement both clinically and behaviorally. But it's completely different because I witness that every day. Those are my patients. What we have figured out that most of our patients coming back after 3 years to do procedure again. Okay, 24 months, published paper, did the same, and I'm showing you one example, and we have a bunch of people. So that's Mirko Filipovic Pro Cup. Basically, he was a Pride champion, K1 champion, and he was about to leave his career. He came to us, and there's a 3-4 opinions orthopedic surgery he should give up because of the damage of the cartilage, incredible pain, effusion, and so on. So essentially, when Mirko came, he came to the hospital, and I did not know about his comments. And let me tell you his comments. Since the trauma, I constantly had pain, knee effusion, water knee, and my doctors were removing excess of the fluid. When I heard about stem cell therapy, I was completely skeptic. So he was announcing in the media as a public figure that he's a skeptic because of the treatment. But see what's happening. Month after the treatment, he calls stem cells, but it's microfermented. My knee effusion was gone, since that never happened again. So what's happened with his life? A year later, he won major tournament in K1. So that's microfermentation. That's a lot of people that we're witnessing, and I was waiting with this data for so long till we have enough evidence, and indeed, we don't understand many things till today. And I'm very careful with every single statement I'm going to tell you, especially about mechanism. But still, we have people who are witnessing, including Luka Modric, including Dino Raja, Boston Celtic, Gary Kasparov, Filipovic, and so on. So I need 5 more minutes. So what is really happening?
5 minutes too long.
Oh, okay. So I'll speed up. So I've been asked before the lecture from few of you just to explain what is the difference if you are going with a stromal vascular fraction proper and comparing technology with core plate plasma. So if you apply PRP, you are really able to get improvement on the VAS, VOMA, COOS, and so on. But please remember, you are not going to see changes in the degenerate index, which is telling you that PRP can be good, but for a short period of time. Okay, our future work is to explore how heterogeneity of the adipose tissue can help, and we are just about to launch data from one of the greatest European projects, analyzing altogether 18,625 patients that entered to the cohort, and we were able to have 339, or altogether 53 with the equal phenotype, in order to understand what's happening, looking everything, synovial fluid, blood, proteomics, glycomics, genomics, microRNA, and so on. So those data we are having in collaboration with our partner from Barcelona. So let me briefly show you the really exclusive data, so artificial intelligence-based generic data fusion model. And what we would like to tell you, there are certain proteins which you are having right here, where you are able to determine predictions and outcome of disease of the outcome. So if you're having IL-8, TIMP1, IL-1B, and so on, you're able to predict that outcome of treatment is going to be fantastic. But Professor Lalos is sitting here. So what we are having here, if you are having proper treatment, you are able to see the changes after 6 months of the certain glycans. So we, for the first time, and same happening with microRNA. So for the first time, we are having power in our hands to understand, once again, on the number of the patient that we are able to have. Out of the more than 10,000, we came to the 53 with the almost same phenotype. So I would like to thank this wonderful group of the people that we work with, and I would like to thank people who are dreaming big. E-Arts was established during our meeting, which is absolutely fantastic. The leaders in the field of the regenerative medicine. So please join the group. And indeed, European Olympic Committee, Medical and Anti-Doping Commission, Klaus, thank you and all friends to be here. And once again, the last sentence. As Churchill said once, cell-based therapeutic arthritis. Now this is not the end, it's not even the beginning of the end, but perhaps the end of the beginning. Thank you so much.